has the capability at that moment in time and can get there fastest. That's what it's going to take. Barrett, can you answer this for me? It's Lakeview, and it's probably a consult. If you can just tell me if it's not an emergency, I'll call him back. Thank you so much. What we really need to be able to see is broadening of these, the hub and spoke model, so that we can get everybody treated. Expanding your networks. And it does require nonstop, like not nonstop, but it requires an effort to update the portal so that it's known right then on the spot whether a service is available or not. Because there's only 2 hospitals that are obligated to have it available 24/7, 365, and that's our 2 comprehensive stroke centers. There are other centers that do this and can do it that may not have it every single minute. Is it emergency? Okay, great. Perfect. Okay, so you're familiar with the initial destination protocols. Basically, you think somebody's having a stroke, unless their ABCs are compromised, in which case you take them to the closest ED. You're supposed to take patients with suspected stroke to the closest Learn Level 1, 2, or 3 center where they have basically attested that they can give IV TPA, because that is time-sensitive, it's emergency. The guiding principles are that time is the critical variable for acute stroke treatment. Protocols that include pre-hospital notification while en route should be used for patients with suspected stroke to facilitate primary destination efficiency. That treatment with IV TPA is the only FDA-approved, I have to update this, medical therapy. And EMS should identify the geographically closest facility capable of providing TPA treatment, transfer patient to the nearest hospital equipped to provide TPA treatment, secondary transfer to facilities equipped to provide tertiary care, and interventional treatment should not prevent administration of TPA to appropriate patients. The Lung Communication Center is staffed every minute, and they have nationally registered paramedics that have an in-depth knowledge of the protocols and can in real time provide information about the availability or non-availability of the services that you think the patient might need. Should not change 24/7, 365 for Learn Level 3 centers. They should always be able to emergently evaluate and treat the patient with TPA. But this number is available if anyone needs to call at any time to get guidance. So what about secondary transfers? This is the existing protocol. If they're still within 8 hours and it's an ICH and they might need higher level, or it's an ischemic stroke and they've gotten TPA, or they might be a candidate for endovascular because they have a big stroke, you're supposed to facilitate transport to a higher level of care, which actually could be another Learn Level 3 center, depending on availability of services and affiliation agreements. And it should be at emergent 911 level in an ALS unit. If the stroke has been going on for more than 8 hours, it's not considered to be a critical transfer. So one of the things that got brought to my attention when we had our Comprehensive Stroke Center visit from the Joint Commission was when they wanted to pull charts of transferred patients post-TPA. And we pulled a chart, and they looked at the chart, and they were like, how far away is, they named a city. And I said, oh, that's about, 55, 60 minutes away. And they said, okay, looks like the TPA, I'm just making up these times because I can't remember off the top of my head. Let's say the TPA was given at noon, and the paramedics picked them up at 12:20, and they arrived to your facility at 1:20, and like, it's fascinating that there's one set of vital signs and not one neurocheck, when the protocol is Q 15 minutes, vital signs, with intervention of those vital signs if necessary to stay within the protocol, and neurochecks not otherwise specified in terms of what includes a neurocheck for the first Q 15 minutes for the first 2 hours, followed by Q 30 minutes for the next 8 hours, followed by Q 1 hours for the remaining 24 hours. Like, that's fascinating. And we say, well, that's terrible. And they're like, yeah, it is. You're going to get dinged for it. And we're like, what? How's it our fault? You're the higher level of care. It is your responsibility to tell your spokes or sending facilities what they need to do in order to maintain the safety of the patients that you are accepting responsibility for. And this was recognized at the state level as a major problem. We had nothing in place, and so we worked hard at the statewide stroke work group to agree upon a document which serves as a guideline. This is not a learned document, but this is what your thought leaders and experts have put together with inclusion of multiple members from various EMS agencies to put together that we all agreed could be done and should be done to maximize the safety of patients who have received thrombolytic when they're transferred from one hospital to the next. And you can imagine, and many of you have already probably noticed, that this has gotten more frequent. Have you all noticed an increased frequency in transfers post-TPA, or no? Well, it will, as we're trying to get patients treated and then shipped to a higher level to get endovascular treatment. It's going to get more common. So we've got to make sure it's safe. So this is the first part of that form. And it basically has the receiving facility's name, receiving facility's address, the accepting the MD's name, and an immediate phone number for that doctor, and a patient label. Any questions about why we have any of those components? Probably not. The next part is the time that TPA had been started and confirmation that the waste has been discarded, a time when TPA infusion was completed, which may be during your transport, so you might need to be the one that fills this out. If it's already been completed before you pick the patient up, it should be filled out for you. And they're supposed to get normal saline running through that same tubing at the same rate that the TPA was going, up to a liter of volume, because that should be tolerable by most patients. So do y'all get the concept of the waste being discarded? If not, please say so. Okay. Because you never want to overdose a patient accidentally. So this is what it says. EMS must call the accepting physician at the receiving facility if any of the below clinical conditions occur or for any change in cardiac rhythm. Document the date, time, name of the physician to whom you spoke. Head of bed flat with the caveat that if poor mental status or secretion management, place the head of the bed at 30 degrees. Make sense? If TPA is still running, stop the infusion and contact the receiving facility physician for any of the following, and we would like you to check the box if you do have to stop it for one of those, or one of these occurs, or even if TPA has been completed. A new severe headache, we want to know, because we're worried about bleed. Increase in the mini stroke scale, which we're going to go over, by 2 or more points, because we're worried about neurodeterioration that might represent bleed. Inability to keep the blood pressure within parameters, we're worried that that represents an increased risk of bleeding. We're probably not going to tell you to stop it. We're probably going to advise on specific treatment to lower it, that is going to be doctor dependent, what they like to use, and the doses that they like to use. If angioedema develops or a new rash, that might be an allergic reaction to TPA, stop the infusion. And I do not recommend giving epinephrine unless the patient sounds like they're developing shock, because what is one of the secondary consequences of epinephrine? Blood pressure shoots up. Nausea and vomiting is common in the setting of stroke, especially when a patient's bouncing around in the back of a unit. I tend to want to treat that aggressively so that we can minimize the chances of a patient vomiting, especially if their head of the bed is flat at the time. Systemic bleeding that cannot be controlled by direct pressure. So if they had an attempt at a line and it's just pouring blood and you can't stop it with pressure, that's pretty unlikely, right? If they're bleeding in their mouth and you can't identify the source to be able to apply pressure, that might be a reason we have to stop. If they have, they start bleeding in their urine, or you see that they have blood coming out of their backside, you can't compress that, you'd have to stop it. Vital signs every 15 minutes with continuous cardiac monitoring. There are recommendations to treat blood pressure if it exceeds 180/105 in the existing American Heart Association Stroke Association guidelines. And there are some choices listed. I mean, there are, of course, some favorites, but not every truck across the state of Louisiana has all of these medications. Ideally, if a patient was started on a medicine like nicardipine, then they would leave you with enough medication to make sure that you could adequately transport the patient at the max rate of infusion of that medication should that be necessary. You should always have something, and it's the sending facility's responsibility to provide you with medications if you do not have them on your truck as it is. And these are, I'm not going to go through the details of the individual choices. If the patient is hypotensive, so their blood pressure is less than 90/60, we recommend a bolus of normal saline at 250 cc's, and you can repeat that times 1. If it remains lower than that, it's important to contact your receiving physician to let them know if the blood pressure is refractory to boluses of fluid. You may want to contact them even before you bolus. I would never be upset about being contacted before that. I want to know. And then oxygen, 2 liters per nasal cannula to keep this at least 92%. Any questions about any of that? Okay. So we just shot a training video through Learn. Money is generated through Learn, and that should be available on the Learn website by the end of the month. We're hoping by the end of the month. And it essentially goes through every single component, including some of the details about the medication management. And I'm hoping that everyone will review it and maybe take the post-test as part of the documented education for this initiative. So this is the part where we have neuro checks every 15 minutes and notify accepting physician for signs of neurological worsening, which we define as an increase in the mini stroke scale by 2 or more points. In our center, we've used this for the last 7 years, and if a patient has a symptomatic hemorrhage, they increase their mini stroke scale by at least 2 points, generally more than that. So what we would like is that the initial assessment before you pick the patient up is performed with you and the ED nurse who was taking care of the patient, so that everybody agrees this is what the patient looks like when you take responsibility for them. And so that time should be documented, the blood pressure and heart rate at that time, and then the components of the mini stroke scale. It's essentially, I'm going to go through the entire stroke scale in a minute, and then we'll swoop back to the mini. And then there's a question about intervention, and intervention is defined as any new medication dose, change in an infusion rate, or patient change resulting in a call to medical control or the receiving physician. Further explanation should be documented in the space underneath this table. And then that final assessment, when you hand off that patient to the receiving facility, in most cases it's going to be in the ICU, or it might be the cath lab staff, or if the hospital is full, it might actually be the ED, should be done between you and the receiving RN, so that you agree this is what the patient looked like when you last saw them. So what about an NIH stroke scale exam? So it is a standardized method to measure the level of impairment caused by stroke. It is quantitative, so it gives you a number. So you can tell somebody, oh, the stroke scale was 8, and I know what that looks like, right? It's systematic, so it actually does go through very specific neurological functions, and it allows for objective comparison of efficacy across different stroke treatments and rehab interventions. In our center, we use the stroke scale every single day. So we know yesterday they were 2, today they were 4, they had 2 extra points for this and this. And that tells me important information about localization, as well as gives me points to plot on a patient's recovery curve. You tell me that their stroke scale was 12 and now it's 6, wow, they got a lot better. So it's very helpful. It allows us to kind of talk the same language, and it allows for the neurologist to prognosticate how a patient will end up if you do nothing. This is not important to know the numbers, but the lower the number, the better. Somebody who has a score over 15 has a moderate to severe stroke. Catastrophic strokes are those over 20. The first step is level of consciousness 1A. This is basically what is their level of consciousness, and it ranges from 0, so remember, lower numbers are better. 0 if the patient is awake and alert, completely responsive. Somebody who's 1 is not alert, but with minor stimulation, they'll open up their eyes and do what you want them to do. If you leave the room for a few minutes, you might find that they fall back asleep, but you're able to arouse them and get them to participate in the exam. Somebody who's 2 is not alert at any point. They require repeated stimulation, often noxious stimulation, to get any response out of them. And somebody who is in coma only responds with reflexive movements and doesn't interact at all. The next one is level of consciousness question. So it's about orientation, and there's only 2 specific questions, and they should be asked in this exact order: the month of the year and the patient's age. And then you get 0 if you get both correct, and you get points 1 or 2 depending on if you only get 1 or not, neither correct. And you should only grade their initial answers. So if they say May, oh no, it's June, you're still supposed to score them a point because they got the first answer wrong. You're not supposed to help or provide any cues. You're not supposed to be like, oh, it's the month when there's Halloween, and get them to say October. That doesn't count. If somebody is aphasic, they don't understand, you're going to end, or they're stuporous, you're going to end up giving them a 2. If somebody is unable to speak because you don't understand what they're saying, because their speech is so slow you have no idea, and if they can't write it, then you're supposed to arbitrarily score them a 1. If they've got an ET tube in, you're supposed to automatically score them a 1. Level of consciousness commands is 1C. It's these 2 commands. Oh, I guess I should say that the reason why you do it in this order every time is because if you have somebody who's inattentive or they're kind of getting dementia, and you ask them how old they are first, that when you ask them what month it is, they often give you the month of their birth because you kind of triggered something and they're going down that pathway, and it's hard for them to shift to a month that's not related to their age. Does that make sense? So I always recommend asking what month of the year it is and then their age. So the 2 commands are open and close your eyes and make a fist and then open it. And you're allowed to mimic. You're allowed to show them what you want them to do. And you're allowed to substitute. For example, let's say they've got the paralytic on one side and they've got an amputation on the other side. Well, you can substitute another command and see if they can do it. And like I said, if they're having problems with the communication, you're allowed to show them what you want them to do. Number 2 is gaze, and it's only part of gaze that's assessed. Not that it's the only part that's relevant, but the only part that's assessed is horizontal eye movement. So I basically have them look at my finger and have them track all the way to one side and all the way to the other. Somebody who has a forced gaze and can't get even past midline will get a 2. Somebody who you can get past midline, but they have a preference and they don't look all the way to the other side would get a 1. And here's an example of somebody who has a conjugate forced gaze. The next part is visual field testing, which can be difficult and depending on the patient's condition. I mean, if they're really sleepy, it's really difficult. Sometimes the best you can do is hold their eyelids open and check for blink to threat and see if they'll blink unequally on one side. But it'll be normal if they can see in all 4 quadrants. They may have only impairment on one side in the upper or lower quadrant, or they might have a complete hemifield cut like you see there. The next part is facial paresis. We score normal if they're perfectly symmetrical when they smile, a 1 if they have some flattening of the nasolabial fold or there's asymmetry when they smile, a 2 if they really don't move the bottom part of their face very well, and a 3 if they're like this. So the guy can move his eyebrows, but only the right lower portion of his face doesn't move. So that would score 2. And somebody who also has impairment of their forehead, looking like a Bell's palsy, would be scored a 3, like you see with this guy. The left side of his face and his forehead is paretic. The next part is motor. So you do each limb individually. The arms, when somebody's laying down on a stretcher, are to be held out at 45 degrees. The legs are to be held out at 30 degrees. And the arms are supposed to count for 10 seconds, and the legs 5 seconds. So, for example, if I were laying down and my arm is here at 45 degrees, I often will hold my hand in front of theirs to make it easier to see if they drift down. Because sometimes you're like, did they drift? I'm not really sure. And somebody who has no drift should be able to maintain this position for the full count. Somebody who has drift will start to drift, but their arm doesn't hit the bed before you finish counting to 10. Somebody who's a 2 is somebody who can raise it up, but it hits the bed before they count to 10. Somebody who's 3 has no ability to lift that elbow off the bed, but they can move it within the plane of gravity. And 4 is somebody who has no control over their limb. There's no movement. And the same thing applies in the leg, but remember, it's only for 5 seconds in the leg. Any questions about that? Okay. If they have an AKA, you're supposed to score them an X. If it's a BKA, you can actually score it as if the leg is there. That's the rule. Ataxia is basically check finger to nose on each hand, and what you're looking for is the course to be altered. You're not looking for a tremor. That's not, somebody who does this is not ataxic. Somebody who does this is ataxic. And the same thing with heel to shin on their lower extremities. Maybe score 0 if there's no ataxia. Sometimes it's difficult to tell whether, when somebody's really weak, whether they are having trouble because of the weakness or whether they're truly ataxic. It does require a little bit of a judgment call because we only are supposed to score it if it's at a proportion to the weakness. So in somebody who's a 2 or a 3 in their arm, there's no point. I wouldn't score that. Somebody who's a drift is where it requires some judgment call. Century, we're supposed to assess for pain, like pinprick. We don't generally recommend you actually walk around with pins, especially since you'd need to discard them in a sharps container, and who's got all these pins laying around. So we generally will use like the edge of a fingernail or one of those little cotton swabs that will break off and make a sharp point. And you're supposed to score 1 if there's asymmetry, comparing right to left, and 2 if they don't feel it at all. And you're not supposed to score like peripheral neuropathy. So if they've got like reduced sensation below both knees, you're not supposed to score that. Language. So we have a lot of different language functions we can test. And you're supposed to score somebody normal if all of them are intact. You score mild to moderate if one is affected pretty remarkably, but the others are completely spared. You're supposed to score severe if they're mute, but they can follow commands. And you score number 3 if they're mute and they can't follow commands either. And how we test it is we have these little stroke cards, which I'm sure you've seen before. We ask patients to describe what's going on in this picture, and they should be able to use full sentences, and they should be able to comment on something on both halves. What might you guess if they only talked about the lady at the sink, but they don't mention the kid getting into the cookie jar? One of 2 things. They either have a visual field cut, or they have neglect. So one of those 2. So in that situation, I would slide the card into their intact visual field and see if they can now see the rest of the picture. If they can, it was related to a visual field cut. We ask patients to read these phrases and sentences to assess their ability to read. Sometimes we can't score this component if they say that they don't have their glasses and they can't see it. We ask patients to name each item on this card, and sometimes educational level will impact the ability to, tell us the name hammock. But generally, if they say a swing that's hanging between 2 trees, we'll usually let that go. We'll allow things like that's a palm. In our Catholic community, we'll call that a palm instead of a feather. That's fine. And some people don't know cactus, but they'll call it a prickly pear. That's fine. And then we assess their articulation. So dysarthria is not about language. It's about the ability to articulate your words clearly so that they're well understood. And you're supposed to score normal if you understand everything perfectly fine. There's no slurring. 1 if you understand at least 50% of what they say. 2 is scored if you have to have them repeat at least 50% of what they say. And then if they're mute, you also score them 2 automatically. But if they're intubated, they get no points. They get an X where it's untestable. So a lot of times when we extubate a patient in the hospital, they have a neuro worsening because now we can score their dysarthria, but we couldn't score it the day before. And we assess for their ability to articulate, asking them to say these words as clearly as possible. Sometimes it's hard with accents, so that we'll have to, if we're not sure, and we'll ask a family, do you feel like they're slurred at all, or ask the patient if they feel like they're slurred at all, because sometimes we're not really sure. And then neglect, this is very difficult to assess, but essentially how we would do this is they say, okay, yeah, I can see your fingers wiggling on that side. Yeah, I can see them wiggling on this side. And then you wiggle both of them and they only see one side. That would be considered a form of neglect. Same thing with their arms. Do you feel that? Yes. Do you feel that on the opposite side? Yes. you have them close their eyes and touch both sides at the same time. If they can only feel one side, then that would be considered neglect. So why should you become proficient? It's a very useful clinical stroke tool to evaluate the severity of disease, and it allows to predict the size of the stroke. It also is a predictor for short-term and long-term outcome. It's the most important predictor of outcome, and it allows for us to have a common language and may be an integral part of that screening process to decide whether somebody meets your threshold for referral to an endovascular center for evaluation and treatment of a suspected large vessel occlusion versus somebody that you suspect is not a large vessel occlusion. Everybody can do it. You can get certified for free at the National Stroke Association website. I think it's $10 a year now from the American Heart Association's website, but it's useful to do, and depending on what your career holds for you, it may be something that is relevant on your CV. So back to the mini-stroke scale. Basically, the mini-stroke scale is these components. It's that level of consciousness. That's super easy to determine, right? That takes less than a couple seconds. You've already determined that before you even think that I'm going to calculate the mini-stroke scale. The questions are easy. What month of the year is it? How old you are? They either get it right or they don't. Pretty fast and easy to assess. Close your eyes, open your eyes, make a fist, open your fist. That's pretty fast and easy. And then even in a moving vehicle, we've piloted performance of assessment of drift. Now, of course, you hit a bump and the arm bounces. You're not going to count that. But the rest of the components should be fairly straightforward. They're laying flat. Arms at 45 degrees for 10 seconds, legs at 30 degrees for 5 seconds. So screening algorithm, I don't know. I think the screening algorithm is not going to necessarily be able to be standardized because some of the components that might go into screening, like advanced imaging, are not going to be uniform across the state from centers that might be referring on to a higher level of care. Most studies would support that if the stroke scale is at least 10, and there's at least one cortical component, meaning either they have a gaze preference or a forced visual field, forced gaze. They have a visual field cut, or there has some language disturbance, or they have neglect, that they are very likely to have a large vessel occlusion. If a CT angiogram can be performed at the referring hospital, that's ideal because you really don't want patients transferring on if they really don't need to. I mean, if patients can stay in their community, that's where they should stay. It is really only these super high-risk patients for whom the evidence supports that the addition of endovascular to IV TPA or endovascular in people who are deemed ineligible for TPA is warranted to give them a higher chance at achieving that independent outcome. I mean, it does raise some questions, right? Should primary destination protocols involve screening for these patients? If so, should a patient with a positive screen for a large vessel occlusion bypass a TPA-capable hospital in order to access an endovascular center? If so, what is that time that's acceptable? 5 minutes? 10 minutes? 20 minutes? Ideally, you'd know the efficiency of that primary destination hospital, right? I mean, if you're going to it would take 10 extra minutes to get to one that has endovascular by bypassing an acute stroke-ready hospital. But that acute stroke-ready hospital's door-to-needle time is 75 minutes, and the hospital that you'd be diverting them to has a door-to-needle time of 45 minutes. Numerically, it's worth it, right? So we really need to work on like a simple computer program where you can just like plug in lasting normal, stroke scale, and where you are and coordinates, and it tells you like the fastest way to get IV TPA is here, so that you know exactly where to take them. And then what about that additional cost of the secondary transfer? Nobody's looked at that. How much money is spent on secondary transfers, and could we predict which patients would have secondary transfers and perhaps reduce the health care costs associated with the secondary transfers? It's a thought. So bottom line, standard of care is IV TPA unless contraindicated. Faster IV TPA is better. The number needed to treat to get an independent outcome in the golden hour, that means that first hour after onset of stroke, is only 2. Stroke code is not over until you've decided that endovascular is not appropriate.